Welcome to the deep dive. Today, we're really focusing in on gallbladder cancer.
Mm-hmm.
If you've got the MSRA coming up, look, understanding this condition is pretty vital. We've basically taken the key info from the sources, distilled it down for a high-yield revision session.
Yeah, the aim is to make it stick.
Exactly. Make it stick. So we'll walk through the definition, causes, management, all that good stuff, plus some memory aids and, example questions along the way.
Okay.
So let's unpack this.
Right. So gallbladder cancer, we're talking about malignancies, cancers that start in the cells lining the gallbladder.
Lining.
Yeah, the epithelial cells. And most of them, maybe 90%, are what we call adenocarcinomas. That's the most common type.
Okay, epithelial lining. Thinking about the gallbladder's job, dealing with bile constantly. So
Right.
adenocarcinoma from that lining. Got it. That's our definition. So what actually kicks this off? What are the main causes?
Well, the precise cause isn't perfectly understood. It's complex, but we do know some major players. Gallstones are definitely leading the pack.
Gallstones.
It's not just having them. It's more about the potential for long-term, kind of intense irritation to the gallbladder lining. That chronic inflammation seems to be a really significant trigger.
Chronic irritation.
Yeah.
Like something constantly rubbing, causing damage over time that can lead to changes in the cells. Makes sense. What else adds to this risk?
So alongside gallstones, we also see chronic inflammation from things like, well, Chroniccholecystitis, that's long-term inflammation of the gallbladder itself,
Okay.
and also primary sclerosing cholangitis, PSC, which affects the bile ducts.
Ah, PSC, right.
Then there's something called porcelain gallbladder. That's where the gallbladder wall actually calcifies, becomes hard. That's another risk factor.
Wow, okay.
Calcified. And of course, genetics can play a part. Certain inherited conditions like Lynch syndrome or FAP, familial adenomatous polyposis.
The colon polyp one?
That's the one. They can increase susceptibility to.
Okay, so gallstones and that chronic irritation, they seem pretty central. Which leads to a good revision question.
Mhm.
What's the main way gallstones increase risk? It's that ongoing inflammation causing cellular changes, right?
Yeah, exactly. That's the key mechanism, the inflammation.
So let's zoom out a bit. We know what might cause it, but who's most likely to get it? Let's really pin down those risk factors.
Absolutely. So gallstones are a cause, but they're also a major risk factor because of that inflammatory cycle we just mentioned.
Right.
Beyond that, older age is definitely a factor. Most cases happen in people over 60.
Okay, over 60.
And interestingly, it's more common in women than men. This might be linked to women generally having a higher rate of gallstones.
Ah, okay. So older women, maybe with a history of gallstones, it's a key profile to remember. What else?
Other things like obesity, diabetes, and maybe a diet high in fat are also considered contributing factors. Lifestyle links,
Okay, right. So maybe a quick memory aid here for revision.
Mhm.
How about go fold? G for gallstones. O for older age. F for female. O for obesity, diabetes diet. L for maybe lifestyle or that underlying inflammation. And D for genetic predisposition like Lynch or FAP. Does that kind of capture the main areas?
Yeah, go fold. That works pretty well. It hits the main points for quick recall. Good one.
Great.
So now maybe we should look at the pathophysiology. How does it actually develop, at the cellular level?
Yeah, walk us through that. How does it go from normal to cancer?
Okay. So as we said, it starts in those epithelial cells lining the gallbladder. Now, with that chronic irritation and the other risk factors we talked about, these cells can start to change. They can undergo dysplasia.
Dysplasia.
Yeah.
Abnormal cells, but not quite cancer yet.
Exactly. Precancerous, sort of.
Yeah.
But if that irritation continues, if the process isn't stopped, this dysplasia can progress further into invasive carcinoma. That's when the cancer cells really start growing uncontrollably and spreading.
So it's often this slow burn, this gradual process.
Yeah.
And that chronic inflammation is like pouring fuel on the fire, pushing those genetic changes towards malignancy.
That's a good way to think about it, yeah.
And once it becomes invasive carcinoma, where does it tend to spread first?
It can spread locally, so right into the tissues nearby.
Yeah.
It means the liver, which sits right next to the gallbladder, the bile ducts, even the duodenum, the first part of the small intestine.
Right. Close neighbors.
And then, unfortunately, it can also metastasize, spread to more distant places in the body.
Okay. So it starts local, but can definitely travel. That analogy you mentioned earlier, the seed of trouble being constantly irritated,
Yeah.
that helps picture it growing and then spreading its roots, so to speak.
Mm-hmm. Exactly.
Now, shifting gears a bit, when someone comes in with symptoms, what else could it be? Because gallbladder cancer symptoms can be vague, right? What's the differential diagnosis?
That's a really important question because, yes, the early symptoms often are vague, so you absolutely need to think about other, often more common gallbladder and biliary
Like
problems.
what?
Well, top of the list is just straightforward gallstone disease, cholelithiasis, causing pain. Then you've got acute or chronic cholecystitis, the inflammation itself causing symptoms.
Okay.
Benign gallbladder polyps need to be considered too. Sometimes they cause issues or they just show up on scans, and you also have to think about infections in the biliary tract or other things causing a blockage in the bile ducts.
So a whole bunch of possibilities, many much more common than cancer, really emphasizes needing good investigations.
Definitely.
So speaking of common, how common is gallbladder cancer? What's the epidemiology look like?
Overall, globally, it's relatively rare, but, and this is interesting, there are big geographic differences.
Oh,
It's much more common in places like South America, parts of Eastern Europe, and South Asia.
huh. Why do you think that is? Linked back to the risk factors.
Very likely. It probably reflects differences in the prevalence of things like gallstones, chronic infections, maybe dietary factors or environmental exposures in those regions that promote that chronic inflammation we keep talking about.
Fascinating. That geographic link really drives home the connection to those underlying risks. Okay, so clinical features. What does gallbladder cancer actually look like when a patient presents? What symptoms should make you think about it?
Well, this is the tricky part we mentioned. The big challenge is it often presents late.
Right.
In the early stages, there might be no symptoms at all, or just really non-specific things, a bit of tummy ache, feeling off, things easily blamed on something else.
Yeah, indigestion or something.
Exactly. But as it grows, more specific symptoms can emerge. Things like abdominal pain, often in the upper right side, jaundice, that yellowing of the skin and eyes.
Okay, jaundice is a red flag.
Definitely. Also, unexplained weight loss, losing appetite, anorexia, feeling sick, maybe vomiting.
Pretty general symptoms still,
Yeah.
apart from maybe the jaundice. Explains why it's often caught late. Are there signs of more advanced disease, things you might find on examination?
Yes. If the disease is more advanced, you might actually be able to feel a mass in the gallbladder area when examining the abdomen, or you might find hepatomegaly, an enlarged liver, if the cancer has spread there.
Okay, so a palpable mass or enlarged liver usually means it's progressed quite a bit.
Often, yes. It really highlights why awareness of risk factors is so crucial for picking things up earlier, if possible.
So how do we investigate then? If we suspected, what tests do we order?
Imaging is absolutely key. We usually start with an ultrasound. It's easy, non-invasive, and pretty good at spotting abnormalities in the gallbladder.
Standard first step.
Then, for more detail, we'd move on to CT scans or MRI. These give much better pictures of the gallbladder, the surrounding structures, and they help us see if it's spread locally or if there are distant metastases.
Okay, so ultrasound first, then CT or MRI for staging. What about looking specifically at the bile ducts?
For that, we might use EUS endoscopic ultrasound, where the probe is inside the body, giving really close-up views, or MRCP, which is a special type of MRI focused on the bile and pancreatic ducts. Both are great for looking at the biliary tree in detail and checking for blockages.
Right, EUS and MRCP for the ducts. So imaging gives us the picture, but how do we know for sure it's cancer?
We need tissue. A definitive diagnosis requires a biopsy, getting a sample of the suspicious tissue and looking at it under a microscope.
How do you get the biopsy?
Often, it's done during an ERCP, that endoscopic procedure that looks at the bile ducts. They can take small biopsies then, or sometimes a percutaneous biopsy might be needed, where a needle goes through the skin directly into the suspicious area, guided by imaging like ultrasound or CT.
Okay, so the sequence is generally image to see it, biopsy to confirm it.
Exactly. Visualize, then verify the cells.
Makes sense. So once it's confirmed, what's the plan? How is gallbladder cancer managed?
Well, it really depends heavily on the stage of the cancer when it's found.
Stage dependent, okay?
Surgery is the main treatment with the potential to cure it, but only if it's caught early enough.
What kind of surgery?
It can range. For very early cancers found incidentally, maybe just removing the gallbladder, a simple cholecystectomy is enough. But more often, if cure is the goal, it requires an extended cholecystectomy.
Extended, meaning?
Meaning removing the gallbladder plus a margin of surrounding liver tissue and nearby lymph nodes to try and get all the cancer cells.
Okay, more extensive. What if it's too advanced for curative surgery?
Then the focus shifts to palliative care. That might involve procedures to relieve symptoms, like putting in a stent to bypass a blockage in the bile duct and relieve jaundice.
Right, managing symptoms. What about other treatments like chemo or radiation?
Yes, adjuvant therapies. Chemotherapy, sometimes with radiation therapy, might be given after surgery.
Why after?
Usually if there's a high risk of the cancer coming back. For example, if the surgery couldn't remove absolutely everything, what we call positive margins, or if cancer cells were found in the removed lymph nodes, the aim is to mop up any remaining cells and reduce the risk of recurrence.
Okay, so surgery is key, but often needs backup from chemo or radiation, depending on the specifics. Now, the tough question, prognosis. What are the outcomes generally like?
Unfortunately, because it's so often diagnosed late, the overall prognosis for gallbladder cancer is generally quite poor, especially for advanced disease.
How poor are we talking?
For those advanced cases, the 5-year survival rate, well, it's often quite low, maybe in the range of 5 to 10%.
Wow, that's sobering.
It is. However, and this is crucial for early stage cancer that's confined just to the gallbladder and can be completely removed with surgery, the prognosis is significantly better. Much, much higher rates of long-term survival in those cases.
Really underscores the importance of trying to find it early, doesn't it?
Absolutely. Early detection makes a world of difference.
What specific things influence how well someone does?
The main factors are the stage at diagnosis. That's the biggest one. Then, whether the surgery was able to remove all the visible cancer, a complete resection. Whether lymph nodes are involved is also very important. And of course, how well the patient responds to any chemotherapy or radiation they receive.
Lots of variables. It really drives home that need for early diagnosis and aggressive treatment when possible.
Right.
Okay, nearly there. What about complications? What can go wrong either from the cancer itself or the treatment?
Well, the cancer itself can cause major local problems by invading those nearby structures, the liver, the bile ducts, the duodenum. This can lead to things like biliary obstruction, jaundice, and eventually even liver failure.
Okay, local invasion.
Then there's distant metastasis, the spread to other organs like the liver, the lining of the abdomen called the peritoneum, or the lungs. That's obviously a very serious complication.
And complications from treatment.
Yes, treatments aren't without risks. Surgery has potential complications like bleeding or infection. Chemotherapy comes with its own set of side effects, nausea, fatigue, low blood counts. And radiation can cause side effects related to the area being treated.
Right, so it's a complex picture all around.
Mhm.
Okay, let's try and bring it all together then. For someone revising for the MSRA, what's the absolute key takeaway message about gallbladder cancer?
I think the most critical point is that gallbladder cancer is often found late because its early symptoms are so vague and nonspecific.
Yeah.
So really understanding the risk factors, knowing the diagnostic pathway, and being familiar with the management options based on stage, that's all absolutely essential knowledge. It's what gives us the best chance, however small, of improving outcomes.
That's a really vital point to hold on to for your revision. And thinking about those vague early symptoms,
Hmm?
it does make you wonder, doesn't it? What strategies could we maybe develop or implement to try and catch this earlier, especially in those people we know are at higher risk? Something to mull over.
Definitely food for thought.
Absolutely. For more top-notch revision resources, don't forget to check out PassNSRA.com and FreeMSRA.com. Thanks for joining us for this deep dive.